Well, hello, everybody. My name is Garrett Schmidt. I am the managing editor for BBC Exhibit Hall, and I wanted to welcome you all to another one of our live webinar series, today hosted by Roji Health Intelligence. And this one's called Smart Strategies for ACOs Under the New Rule. A lot of great practicals here. There's going to be some really great information. I got a sneak peek earlier this week at what they were discussing. So I think you'll really enjoy the presentation today. A few items of note before we get started. As usual, this is a traditional webinar format, so you don't need to worry about muting the mic or your camera or anything like that. We can't see or hear you, but as I always say, we do want to hear from you. So we're going to have a time for some Q&A towards the end of the presentation. So if you have a question at any point, go ahead and submit that using your control module. There's an actual area for that that's different than the chat. So go ahead and drop it into the question box there. And then we're going to get to as many as we can today. It's a popular topic. We've got a lot of folks that have registered and are on the line with us right now. So if we don't get to yours for some reason, that's okay. Someone will reach out to you afterwards and make sure to answer your question. So even if we're just wrapping up at the last minute, go ahead and ask your question. We're going to get to it if we can. And finally, the session today is being recorded. So what's going to happen is when we're done, you'll receive within an hour or so after the conclusion of the presentation, you'll receive a link to where you can actually view the session and download the slides, that kind of thing. And we hope that you will do that and share it with your friends and colleagues. So we'll get that to you about an hour after the presentation concludes. Finally, without further ado, wanted to briefly introduce our speakers today. We have Ms. Terry Hush, and she is the CEO and co-founder of Roji Health Intelligence. And we have Mr. Dave Halford, who is the Chief of Client Team. And so excited to hear from you guys. Welcome.
Thank you.
Thank you, Garrett. Well, we have a lot to cover today. I'm Terry Hush, and I'm going to get started, and then I'll be turning it over to Dave for some of the details of the 2,000-page new rule that we're going to explain in about, I hope, around 40 minutes so that we can leave time for questions. A little bit about us. Our mission is value-based healthcare. We provide technology and services to do that. And one of the key points is that we are a CMS qualified registry for QPP reporting. And we report all the options that we're talking about today based on aggregated data. And we distinguish ourselves based on services, including strategies for our clients to excel under value-based care initiatives. So some of those smart strategies we'll be talking to you about today. This presentation is specifically geared for ACOs and providers who are looking at the future of value-based care and APMs and are looking at their options for quality reporting, since that's one of the key game changer items of the new rule, and looking at the aggregation of data that's required under APP reporting. They're looking at higher risk payment models, figuring out how to survive financially under those payment models, trying to significantly improve cost performance and transform patient care. So if you fit the bill here, you're in the right place. What we'll cover are the best strategies to propose the items that touch ACOs under the new rule. And these 5 areas are the keys. First of all, there's the option for reporting Medicare-only patients through the APP reporting method. Secondly, there's a revised attribution methodology to include new providers under the new rule for ACOs. There's updated regional benchmarking, the MIPS value pathways for ACO specialists, and the requirement that ACOs help providers have certified EHRs. So what else do we want to fold into the environment in which we're looking at these strategies? Well, one is the growing movement towards risk in value-based payment models and looking at other models that are coming online. The second is the competition for healthcare corporate healthcare ACOs for providers and patients, because what corporate healthcare does the traditional providers also will need to take into consideration in their planning. There are the new CMS payment models. Just last week, or I could be losing track of time, the week before, AHEAD was announced and 3 additional are planned for this year. There's an emphasis on health equity, which seems to be growing. And then, not to minimize it, there's a federal budget crisis, which we already are beginning to get the crux of right now, that is looming behind all of the Medicare spending and will have some effect on these policies. So the first thing we want to know is a little bit about what you're concerned about so that we can address it in the presentation. Maybe we can change our time or our minutes associated with each of these initiatives. So what's your biggest worry under the new rule? First of all, you may be snoozing like this furry dog here and have no worries at all. Secondly, you may be looking at the reporting options, and that's your biggest concern, or data aggregation possibilities in that big arena. Third, you may have effects of attribution on ACO results, or the requirement for certified EHRs, or anything else.
Okay, we pulled up the poll here, so you should see that on your screen. So go ahead and take a second to answer here, and we'll give folks a minute to do that. And this is a choose one. Okay, we've still got some folks answering, so we'll give it another few seconds here. Okay. A lot of results coming in. We'll give it about 5 more seconds and then we'll close it down. So about 5, 4, a long 5 seconds, 3, 2, and 1. I don't want to cut anyone off. Here we go. Okay, we're going to go ahead and wrap it up now. There we go. And then, Terry, I'm going to bring the results here onto the screen. Are you able to see that?
Only 3% have no worries. Okay.
Optimistic crowd.
Well, no, that's not an optimistic crowd. We have a lot of worries here, a lot of worries. Okay, well, we'll take care of these worries today.
Do you want me to pull it down now?
Yes.
Okay, here we go.
All right. Do you have to change the presentation? Because I'm seeing myself on the screen.
Oh, we still see your slides, so you should be able to just advance forward.
Okay, but I can't see the slides. Okay, just a
Uh-oh.
second. I'll just move them over.
We're working live here, folks.
I'm not able to see the slides, Garrett. I can't move
I
this.
see your mouse. I see your mouse on the slides.
Okay, can you see me still?
Uh-huh.
Okay. All right.
All right.
First up, let's address the 60% of people who are worried about the options in Medicare reporting. And for that, I'm going to turn it over to our expert in Medicare reporting, who's Dave Halpert.
Thanks, Terry. All right. Well, as we know, there are 3 reporting options under the alternate performance pathway model for reporting. The first is all patient clinical quality measures. The second is electronic clinical quality measures. Each of those require all patients, regardless of payer or lack thereof. And then finally, what has been proposed this year are Medicare CQMs. These are for Medicare patients only, and only Medicare patients who have had an encounter with a provider that would drive attribution under the ACO. And we'll talk about how it's realistic for some, but not all ACOs, and the impact on your ACO will be uncertain. We've talked about some of this before, and for a deeper dive here, there are a couple of URLs here that you'll be able to, you don't have to frantically copy them down now, they'll be there in the slides for you when they're distributed. And so we hope to provide you with that information as well.
And also we've included a link to the website here because we have some quick one-page tip sheets, one specifically on the Medicare CQM issue.
All right. All right, first let's talk about the Medicare CQMs. They were added to respond to some of the ACOs concerns, and they do limit quality reporting to Medicare patients versus all patients. That was a big concern. And there is also some relief for ACOs because CMS is planning on providing a claims-based list of patients that will establish, for the most part, the eligible denominator. But there is a reality in there too, is that ACOs of 10,000 or more patients are still going to need to look up and aggregate data to populate numerator scores. So even though you're only looking at Medicare patients only, it is not the 248 Medicare patients that are a part of your web interface sample. It is still more patients than you will be able to go from practice to practice and abstract charts. Furthermore, the list of eligible patients will come at the beginning of the submission period, which will be the first week of January, but that is not going to be a complete list. And the reason for that is there's a claims runout period. And so there are going to be patients that are seen in December and maybe even going back into November that will be eligible patients for Medicare CQMs, but they're not going to be on that list. And so what will happen is that if you just send that list back to CMS, the same denominators, they'll know that you didn't actually report on all patients and your quality will not be true, accurate, and complete, which is what they require. There are some other considerations for Medicare CQMs as well. First of all, are you certain that they will not reduce your quality score? When you are looking at Medicare patients only, you're excluding the people who are younger and maybe healthier. So people who have been more recently, let's say for example, more recently diagnosed with diabetes or hypertension and may have better control than some of those who are Medicare only. Next are the people effort for manual lookups, a trade-off for ACO functions. In other words, if you are going from practice to practice reviewing everybody's charts, is that really the best use of time for your staff? For example, are you curtailing options to participate in some of the other models that are out there, like AHEAD? And finally, does your plan for reducing costs require data aggregation? These are all going to be critical. If your plan for reducing costs requires data aggregation, there really isn't a need to limit yourself to CQMs. So talking about data aggregation, is apprehension about your aggregating data hurting your vision? Is it so scary that we don't want to do it because it looks really hard? And that's what we want to focus on now, and we'll talk through a little bit of these concerns. The reality is that eCQMs and CQMs need aggregated data, and therefore you're going to need some sort of technology that will help you aggregate your data. It's not something where your EHRs are going to seamlessly talk to each other. I'm sure those of you on the phone have experienced some of those woes already. And so what you will need is somebody who is able to aggregate that data to you and bring you patient-centric results. The patients need to be matched across the ACO, meaning that if there is a patient John Doe at practice A, you need some way to know if that is the same John Doe at practice B, because all of you are not going to have the same medical records. You need to have some sort of patient matching technology. Each patient is eligible for a measure based on encounters with each of the individual practices. And so while one patient may not be eligible at one practice, they are eligible at the ACO, and having that practice by practice lookup piece is going to help you help ensure that you are able to actually capture this information at the point of care. Only the EHR data is going to have the entire patient population, and so yes, you'll have claims data for patients who are Medicare patients, but you're not going to be able to see everyone who should be in an eCQM or CQM. And those measure numerators for the outcomes are also only available in the EHR, even if you do have a claims feed with all of your private payers, which as far as I know, nobody has, you're still only going to be able to see the claims themselves. You're not going to be able to see those non-billed clinical values, the systolic and diastolic blood pressure, the lab values, etc. And since each of those measures requires the latest value of measure for those patients, you need to have something to be linking those patients to and data systems together. In other words, you can't simply add up your results from practice 1 and practice 2 and practice 3 and put those forward. You need to be able to have one comprehensive record to say of all of the patients that have visited our ACO, the most recent blood pressure value for this eligible patient is whatever, and that will only be available to you if you have aggregated your data. And of course, just for fun, there are a lot of blood pressure values, even for the same patient within an EHR. So you're going to need somebody who can differentiate one of those from the next. There are 3 measures for direct ACO reporting. Diabetes, hemoglobin A1C is the patient's most recent A1C less than 7%. The screening for depression and follow-up plan, and then controlling high blood pressure for patients with hypertension is the blood pressure less than 140 over less than 90. Each of these measures is definitively linked with health equity as well. So they are quality measures, but there is a marker of health equity within each of these. So an easy example would be to look at patients who have high blood pressures or high A1Cs. In patients in underserved populations, grocery store deserts, fresh food deserts, those are going to be things that are going to play a pivotal role in changing values. And so they are linked with both health equity and quality. So there's a lot there. And so the aggregated data enables better foundation for understanding and resolving some of those health equity gaps. There needs to be a way for you to look at them more deeply besides these patients have high blood pressures or high A1Cs, and that's all there is to it. There needs to be a deeper dive. So what you need to do is you need to be able to balance your APP reporting. You need to get the right value for your goals. It can be a costly effort, not as costly as people believe, but there is a work and time trade-off with other priorities. And so you need to be able to make sure that what you are doing in terms of your data aggregation for APP reporting can benefit you in other ways. It shouldn't be tied to just quality reporting, because then then the expense cannot be distributed. It can't be something that you can economically explain. But when you are able to work that in with other priorities, it becomes a much more feasible proposition. And that's what we want to talk about here, is getting the most for your investment. It is too expensive for a single effort. If your future goes beyond Medicare value-based care, you should plan for that. Are you going to be negotiating with other private health plans? And do you want to put your quality scores at risk just by looking at information related to a certain key set of values? There is no guarantee that one health plan is going to look at the same information as the other. And also there are some other quality things in there that are going to be looked at, not the least of which you all know are all-cause readmissions and admissions for patients with chronic conditions. So these are going to contribute to your quality score as well. It goes well beyond reporting. The cost of your data aggregation efforts are going to be dependent on a few factors. First of all, how many data sources are in your ACO? And what you need to be prepared for there is to speak with each practice so that you have an understanding of which EHRs are in play, how many providers, practices, etc. are on each EHR. Are there different installations? Asking these questions up front is going to be able to give you more information about how long will it take, how many data sources are involved, how complicated will the process be in general. Will that affect what sort of measures we report? If we do not have the ability to export QRDA1s for all of our practices. Well, that automatically entails that we are going to have to report either Medicare CQMs or the regular CQM options. And then finally, your cost is going to be dependent on flexibility and support of your data aggregation vendor, support of your EHR vendors. There are a lot of things that go into this, but by doing the upfront preparation, you're going to be able to save yourself a great deal of time, money, and aggravation. So time is optimized with data. So data, especially that clinical data, is a valuable asset. It is like rocket fuel for your ACO or your Beardy, shooting down the hurdles there. The trade-off for manually collecting data is shortchanging initiatives. So if you are trying to manually collect all of this data that you need for APP reporting or other programs, those resources that are collecting that data on their own, going from place to place, those are people who are not working proactively with patients, trying to find interventions for targeted set of groups that are going to be able to improve. So instead of actually improving your results, you are going to just be stuck on a flatline outcome because you're too busy collecting that information than you are acting on it. There's no real clear winner between all patient CQMs and eCQMs. It is going to be dependent on how good the documentation is from practice to practice in the EHR. eCQMs are very unforgiving, and so the information may be in your EHR, but if it is not documented in the place where your EHR has specified that your measures will be pulled, you could be sabotaging yourself for the sake of reporting ease. So yes, it may be easier, but your performance will suffer. So it will be dependent on a number of things, and the right aggregation partner is going to be able to help you walk through this. So moving along, let's talk about the smart strategy for choosing an APP reporting option. Your goal should be to get the richest clinical and transactional data. So transactional being which patients saw which providers, what occurred there, and you know, diagnoses, procedure codes, etc. The clinical data being both things that you can see from previous transactional data, but also those non-billed clinical values, PHQ-9 scores, blood pressure values, and A1C values. And what you should be doing is tracking both Medicare and all patient CQM. So even if you decide that you do want to report the Medicare version only, track them simultaneously so that before you report, you have an understanding of which method is going to essentially put your best foot forward. Both are acceptable, but if one of them shows very different values, performance values compared to the other, know that in advance, and the right data aggregation partner will be able to help you with that.
And let me add, it should not cost you anything more to be able to look at both of these side by side, because once the data works through the vendor system, it's it's just two different views of your quality reporting.
That's an excellent point. Yes, it's just a question of which ID goes along with your measure scores. It shouldn't cost anything more. All right, moving on to attribution to include alternative providers. I saw that this was second place in terms of everybody's concern for today, and so I want to talk briefly about some of this here as well. So yes, more patients are going to be attributed to your ACO. According to the proposed rule, if your patient sees a primary care physician within the last 24 months, but also sees either an NP, a PA within the last 12, that will count towards your attribution. And that effect is likely to increase 3%, possibly more, depending on your ACO and the method of care that your patients receive. So the question that I know everybody's asking is there going to be an effect of these changed attribution methodologies on your costs and quality. So if you aggregate data amongst all of your groups, you'll be able to compare populations before, populations after, and being able to see things at the all patient level is going to give you answers to both the cost and the quality impact. Medicare only may be a little more challenging. It may be a smaller sample, it may be more difficult in general to get a read on your entire population. But if you're looking at things at the all patient view, it's going to give you a much better view of how you stand with regards to these attribution changes on cost and quality. It could very well go either way. It's common to see higher cost per patient for alternative providers when they're seeing patients that require more visits. We know that in underserved communities, sometimes this is the only type of primary care that is available, and so that will obviously have an effect on your cost and quality as well. On the other hand, it could just be that that these patients are very healthy and do not need to seek out complicated care. So it could go either way. So you need a smart strategy for addressing impacts of attribution. The first thing to do, again, we'll keep coming back to it, aggregate data and compare patient episode results for chronic conditions. So if you are looking at patients with hypertension or patients with diabetes, you want to know how much it costs to take care of them for a year, and then you also want to know where you are having issues with patients with persistent poor control. What is behind that? It's more than just looking to see who has high blood pressures or high A1Cs and who does not. There are a lot of factors in there. Are there patients with behavioral health diagnoses who have not seen a behavioral health professional? Are there patients who have had the same drug class forever and ever, and their results continue to be poor? There's a lot that goes into this, and your partner can help you with that. Again, tracking both Medicare and all patients is going to be useful, because you'll be able to see, first of all, as your population, your Medicare, as your private health plan population ages into Medicare, you'll know where you stand. And then finally, you'll be able to more effectively choose your best results for APP reporting, depending on the type of measure that you're using.
And let me add something to this, Dave, because estimating the actual cost impact is more than tallying up your claims and then dividing it by the number of patients. As the first bullet point indicates here, you really need to dig in to the predictive costs of those patients based on their clinical criteria in chronic conditions, and also look at your specialty costs. So that's the thing that will really throw your attribution out of whack, potentially.
Yeah, absolutely. All right. Next, regional benchmarking. There were some interesting points in the proposed rule that came out regarding regional benchmarking here. So without data-driven methods to address these costs, you are a sitting duck to CMS's benchmarking formulas. So quick review, the blended benchmark update factor is 1/3 of the ACPT and 2/3 a regional national blend. And so that change in regional benchmarking is going to be critical for ACOs that have high market share. If you are essentially if not the only game in town, one of the great big players in your area, the regional benchmarking is absolutely key to ensure that you don't outperform or perform so well that you wind up ratcheting your performance benchmarks to an unattainable level. So there's the big change that CMS has proposed is by capping the prospective HCC risk growth on your service area, capping that between the performance year and performance year 3 independently of the ACO. And what that's going to do, it's going to mean that if your ACO is serving an area with high HCC scores that are above that cap, your regional component is going to be increased. And what that means is that if you have high market share, you're going to not necessarily be incentivized to use coding insanity as more of an artificial benchmarking strategy. I mean, certainly you want to code accurately, but there are some out there who are coding aggressively in order to sort of keep up with that regional benchmarking score. And so the final effect is that ACOs are going to be able to thrive in regions with proportionately more high-risk beneficiaries when that was something that was not necessarily attainable before. So the SMART strategy for addressing benchmarking and costs, regardless of formula, ACOs need the tools to address the total cost of care and what goes into those costs of care. What is driving persistent poor control? Improving the outcomes of your patients is always going to be a tug of war between time and resources. And so what you need is accurate coding to define populations that can benefit from specific and efficient interventions. And in doing so, you will not hurt your benchmark. And that's something that is a great benefit to ACOs who have either very high market share or who practice in underserved areas, or especially a combination of both. It's going to be looking accurately at your population so that you're able to find the precise intervention that is going to get you the most bang for your buck. There is only so much that any of us can do. Despite our best efforts, we've not been able to add that 25th hour into the day. And so this is where this is what you need to do. You need to be able to focus on something specific and measurable.
Okay, this is my turn, right, Dave?
Yes.
And I'm going to talk about MVPs for ACO specialists. So the key about specialty care is that we see it changing in the future and coming under the value-based care initiatives a lot more strongly. And so CMS is really zeroing in on specialty care costs. They're mentioning it in every single rule and in every strategy refresh now. So I think that one of those three new payment models we'll be seeing in the future will have to do with specialty care. I would not be surprised. What we're seeing now are statements such as they'll consider rate negotiation with specialists. We know that they're already focusing on expanding the specialty care models, and several of them have been updated recently. They're now looking at the MIPS value pathways for specialists, because specialists have been kind of hiding in the whole group reporting mechanism under MIPS. So this is a way of pulling them out and focusing on specialty care. And then the whole MIPS program is also going to be calling out specialists, because it will require eventually subgroup reporting, which include the practices that are focusing on specialists. The proposed rule hints at initiatives to report, like points or something, but we don't know exactly what the final rule will say about what those incentives really are. But with specialists driving about 40 to 60% of the total care costs, we know that specialty care will be a focus in the future. And so it behooves ACOs to begin to plan for this in their own initiatives. There are 11 MVPs in 2023 that are specialty focused, including emergency services, cancer care, heart disease. You see the list. And these are really high volume procedures. I think we'll see some additional coming in 2024, and which are larger and more inclusive. Mental health, for example, rehabilitation, women's health, infectious disease. So I think that we will continue to see MIPS value pathways that are starting to push the envelope on specific issues in specialty services quality and the appropriateness of specialists delivering care as opposed to primary care physicians. So what are the effect of this specialty MVP reporting for ACOs? Well, one may be bonus points. Unclear what those are at this point. But they I think the idea is that they may provide a possibility for ACOs to reward specialists for engagement, which would be a really interesting and new positive thing. CMS is requesting input from ACOs to, and I think it's an invitation that ACOs should really examine what they would like in economic and quality pilots with specialists in their communities that might help them bring down the total cost of care or improve quality or provide higher equity of care. Those could range from anything, but I think CMS is really putting the invitation out there, and it's important to respond to that now. ACO participating specialists should lead to data sharing on specialty outcome and practices and generate a basis for discussion in ACOs. Not many ACOs are focusing on that right now, but I think it's an important initiative that could and should begin based on the data that's already being aggregated or in claims for the ACO. So the smart strategies we see, don't let your feet touch the ground here, are first of all to encourage MVP reporting and data sharing with specialty practices. And that means whether your specialists are actually participants in the ACOs or they're part of your referral network, it's good to begin discussions with the referral networks and get those off the ground now. Engage specialists in ACO patient episodes. This is a vehicle that we take very great pride in because we've examined all the different high volume procedures and are able to identify the variation in care and costs across the spectrum, which is important information for ACOs to collect as they're really at the nexus of referrals. Helping specialists succeed in MVPs is going to be very important. Folding them into improvement programs and specialty care models with ACO staff or financial investment based on the return on investment to the ACO would be really positive initiatives for the future. So here's one people are worried about, which is the requiring ACO providers to have certified EHRs. So I think everybody is pretty familiar with the spectrum of EHRs in use among physician practices, and it's still kind of the Wild West. We've seen a lot of consolidation onto larger systems, but we have many, many practitioners still in very initial, low-level, cloud-based, not very expert systems that may need some help. And it's those systems that are driving ACOs to be concerned about data aggregation and the ability to aggregate data and provide APP reporting. So that data insufficiency is an obstacle to CMS progress too. And one of the reasons that we think this is on the table here is that it's an obstacle to health equity. They've gone through a lot of different communications about defining the standard of care in health equity, believing they can't collect this data, but that somebody has to collect this data. And so the way to do it is to force providers to collect it, and that means ACOs. Multiple systems stall ACO adoption of data-driven strategies and APP reporting. So it really is an important thing for ACOs to take a role in helping their providers advance into data-driven strategies. And in the future, that will be the basis for artificial intelligence initiatives that help the ACO. Poor interoperability hurts the ACO in care coordination and communication, engagement with patients, engagement with clinicians. So the opportunity here is really for the ACO to have a single system or lower the number of systems in use by practitioners and to help model and improve the number of systems available. So those are the good parts. The bad part is that, in particular from specialists, there's a key concern about the privacy of data, in particular financial data. So if you're entertaining a war, the fastest way to a battle is to reveal financial information. So there needs to be some strategies around the use of data, the sharing of data, the protection of data from view across the entire spectrum. The cost infrastructure, though, is driving physicians to MSOs and ACOs that are collecting that data. Physicians are asking for more support, and they're asking for cost data and shared data. And they understand that risk is coming and they want to be prepared, or they wouldn't be joining these organizations that have a business model which is focused on risk. There may be a universal dislike of documentation in the EHR, but if the EHR is an advanced EHR, AI solutions are really promising to fix those things, like natural language protocol, help encoding. You see Epic and Cerner doing those things right now, and really changing the spectrum of what's required for physicians in terms of workload. So the smart strategies that we think ACOs should be focusing on, first of all, many ACOs have really not done a very thorough job of documenting what systems physicians have now. And it really is a good first step for you to take to prepare yourself to see, well, what are we starting with? And where are these in terms of age and functionalities? Secondly, evaluate your ability to expand a big stakeholder system if you have one. If your largest bench holding practice or stakeholding practice is on Epic, it is possible to expand that to your independent practices, or you may put and consolidate all the independents on another system or several. Consider time-saving features in your decision criteria, like the natural language protocols and some of the efforts to reduce documentation requirements for physicians. You don't need to go for one system. A smaller number is a reasonable goal. The real issue is, are the systems capable of data aggregation? And are they able to allow interfaces for your most important initiatives to appear at point of care for your clinicians? Data is just as important as functionality, so you need to ensure that it's easily exportable in multiple formats through any system that you're in the process of choosing or in joint discussions with your physicians. And most important, test the access to clinical data. Don't assume because a vendor tells you that you can access clinical data that you actually can. You have to be able to test all those functions. And you want to ensure that that system will allow inbound data like interventions and finding at the point of care where the physician has the patient with them. Just broaden the scope a little bit in terms of all the different initiatives we're considering in the context of this rule. CMS said recently that MSSPs are the core engine for value-based care. But don't forget that a few years ago, they were threatening to take down the MSSP program and do Medicare direct contracting and promotion of Medicare Advantage. So things change. Things change politically, and things change in administrations in CMS. So you need to think in terms of moving forward with value-based care in a way that is going to protect you under all of the different environmental situations present. There are clear trends towards risk-based payment models, and not just CMS, but all of the private plans are moving in that direction. Corporate healthcare and equity-backed practices are no longer just a trend, they're accounting for over half physician employment. Data-driven solutions are everywhere, and AI is exploding on top of all the databases that are allowing for data-driven solutions. So your best strategy overall is to arm yourself with the infrastructure and the data for you to do what you need to do to excel in the market. And now we're open for questions.
Okay. All right. Well, yeah, we've there's obviously a lot of information there that we've covered today, and so thank you both. And yes, we do have some audience questions here. So if you have a question that you would like to ask, go ahead and you can use your control panel that you have to submit a question there, and we'll get to as many as we can. So in no particular order, let's go ahead and open it up. First question is this: how can we be sure that our data is aggregated correctly?
That's a really good question. I would one of the things that we do, it's something that has been approved by CMS for a data validation strategy, is to actually get down into the patient level detail and physically, for a sample of patients, exchange securely information with our clients so that we can see that the information that is being displayed on our registry actually is meets that source of truth in the patient record itself. So in other words, we'll have a blood pressure with a certain date for a certain patient. So the value, the date, the patient, and we need to be able to ensure that the ACO can produce that value. And if they cannot, then there's obviously a break in the system somewhere. Also, of course, having all the results visible all of the time means that people are easily able to identify if there is some sort of issue, if something just doesn't look right, and to be available to address those questions as they come.
Great. Next question here is, will it matter if we have practices on different installations of the same EHR?
Yes. If the without wanting to call out any EHR in particular, the rule of thumb is that if you have seen one installation, you have seen one installation. And then there's also some other factors in play. Documentation is going to be different at different sites. So even if you do have the same installation, there is no guarantee that things are going to look exactly the same from one place to another. So definitely being able to identify where those discrepancies lie and addressing them in terms of more creative data solutions. So it may not be a QRDA, it may be a QRDA for one practice, but for another practice, you may have to go the flat file route to ensure that all important values are grabbed. So yes, it definitely does matter, and I will take it a step further and say, even if you do have one installation, it may not be a silver bullet.
That's a good point. That's a good point. Okay, next question here is, do you think that as an ACO, we can do the collection internally, or do you think a vendor is necessary?
I would say that a vendor is probably necessary because EHRs are point of care tools, and they are able to trade patient records back and forth, but that they are not necessarily data aggregation engines. And so if you are looking at somebody whose job is to integrate data from disparate sources and ensure that everything syncs up in terms of patient matching, in terms of everything else, you really do need a specialized firm for that.
Let me add to that a little bit. I think depending on the expertise and size in particular of an IT shop, some very large systems certainly have the capability of aggregating and have worked through the issues on creating a common patient repository. That doesn't mean that they have the right patient matching algorithm, or that they're collecting all the information that they are going to need to both monitor cost and quality. So with that caveat, I think larger systems are already doing a lot to aggregate their data, but it doesn't necessarily fit into the measures engine for reporting. So there's a difference between aggregating the data and using that data for reporting, or being able to report accurately. CMS for a qualified registry has to validate that we've got every measure correct, that we've got all the diagnoses, the exclusions, and it's extremely complex for every individual measure. The patient has to have this diagnosis in a certain time period, has to have seen a physician in a certain time period, and so on and so on. Dave, you can go into more specifics on that. So would we work as a reporting entity with aggregated data? Yeah, we'll certainly test it, but it doesn't, I think that there's a risk, and organizations just we need a lot of testing about that data, and it needs to be matched up with other sources.
All right. Yeah, good answer to that. Next question is this. How will digital quality measures affect data aggregation?
They'll actually, just the next logical step. With digital quality measures, one of the things that CMS has stated that their goals are to ensure that a lot of these are patient-reported outcomes and or remote monitoring. And so these are all going to be different sources of data. And of course, if you're looking at patient-reported outcomes, having an accurate patient matching algorithm is critical. And so with digital quality measures, we're looking at results from lots more systems. They're not going to necessarily just be patients. It's going to be a lot of aggregation between immunization registries, syndromic surveillance registries, patient-reported outcome tools, and on and on. So data aggregation is going to continue to be a key part, particularly since as all of these are coming, yes, there is an increased push for interoperability, but there is no unique patient identifier out there. So even if you are, even if you are on just a single system, you may have one patient medical record number, but the information that is going to be coming in from elsewhere may not identify the patients in the same way that you do.
Yeah, that makes sense. Great. Next question here is, Terry, you had mentioned AI implications several times. Do you have any thoughts about the upcoming impact of AI on APP reporting?
I have a lot of thoughts about AI generally. And I don't know about AI and APP reporting per se. I haven't really given the idea a lot of thought in terms of the reporting aspect of it. I think the opportunities in AI are enormous, and the ability to collect data better, have more data at ACOs' fingertips is going to be paramount in the future. Just to be able to affect the cost of care and affect the patient's outcomes is going to be important. SDOH will be a huge area to be able to glean data that's hidden right now and not have to have a lot of hard work by intake on patients or a continual refresh of SDOH data for patients. AI will do that job if there's enough good data in the system to be able to farm it, and particularly coming from patient statements, interviews with physicians, analyses. I mean, our patient episodes of care identify patients who probably have health equity issues and just need to be then referred back to the client so that they can begin asking those questions. For example, patients who show up with persistent poor control and diabetes, but are only on insulin and have been on insulins because we're longitudinally tracking outcomes, have been on insulin for years. So that's probably a financial issue. It's probably an affordability issue for that patient. And so SDOH will a lot be resolved by AI, as will a lot of issues that physicians have to deal with right now in documentation and workload.
Awesome. And as a little teaser, I think we're going to have an upcoming webinar at some point here about AI in value-based care, which I'm super excited about, that I believe Terry will be doing for us. So stay tuned for that. We'll be reaching out at some point here soon. But that is all the time that we have for today, unfortunately. If you do have a final question, again, you can go ahead and submit it. We're going to get to we'll get to you through email afterwards. But I just wanted to say thank you again to our speakers. Thank you, Dave. Thank you, Terry. There's a lot of great information here. And as we close out, I'd like to encourage you all to visit the BBC Exhibit Hall Roji Health Intelligence booth, which you'll see on your screen here. So if you head over to bbcexhibithall.com, and you'll see that, and when you download the slides, there will also be a hot link there that you can go ahead and visit. There's a lot of great resources there. You can read up on them, do a little homework on them, really educate yourself on what they're doing, their abilities and solutions as well, to see if they can help you. And feel free to reach out to them there. And then finally, if you'd like to reach out to Terry or David, you can do so here. Their information is on the screen. And again, this will be in the slides that we're going to be sending out later. So feel free to reach out to them to continue the conversation, or you can reach out to me. I'm happy to facilitate an introduction for you if that's easier. But I wanted to thank you all again for coming and spending your afternoon with us. Hope you have a wonderful rest of your weeks. See you on the next one. Bye-bye.
Thanks so much.
Thank you.